All right, welcome everyone to the Leukemia and Lymphoma Society of Canada's webcast called Pharmacist Training, Oral Treatments for Chronic Leukemia, From Understanding to Support. Today, Jennifer Voisey, clinical pharmacist, will provide an overview of the effectiveness of treatments for CLL and CML. She will help you recognize the phases of CML in order to validate the starting doses, know how to assess the risk of tumor lysis syndrome in CLL and recommend appropriate prophylaxis, take charge of oral treatments for CLL and CML, monitoring and managing of side effects, understand the importance of adherence to CML treatment, and how to assess the severity of hematological toxicities. So to begin, let me introduce myself. My name is Charlotte Hall-Coates, and I'm the Community Services Manager for the Atlantic region of the Leukemia and Lymphoma Society of Canada. I will be the host of today's online event. The presentation will last approximately 90 minutes and will include a 15-minute question and answer period at the end. Since there are many of you, we invite you to type your questions or comments into the Q&A box of your Zoom panel throughout the presentation. Please remember to type them into the Q&A box because we will not be monitoring the comments box. So it's really important that you do it in the Q&A box. All LLC staff, an LLC staff member will be monitoring to answer any technical related questions that you may have. I will read some of your questions at the end of the presentation during the question and answer period. Before we begin our main presentation, I would like to share with you our mission and highlight some of the resources that you may find helpful for either yourself or someone that you know. At the LSC, our mission is to cure blood cancers and to improve the quality of life of those touched by blood cancer and their families. Ultimately, we are here to serve the community. We offer guidance and support to people affected by blood cancer every step of the way. Next slide. We offer a variety of educational resources and services for those affected by blood cancers as well as for healthcare professionals. In addition to disease information booklets, fact sheets, and videos, we also offer other services such as our peer support program, virtual support groups, a multitude of webcasts and podcasts, an online COVID-19 resource center, and access to a community services manager in every region. We invite you and those affected by blood cancer to visit bloodcancers.ca to learn more. Next slide, please. So what can we do for you as healthcare professionals in your communities? First, we offer free tear pads to help facilitate patient referrals to LLSC and our services. You can order your very own tear pad by calling the toll-free number or by sending us an email at info@bloodcancers.ca. We also have mindfulness and self-reflection journals available for download on our website. This can be a great tool to offer those affected by blood cancer, no matter where they are in their blood cancer experience. Next slide. Moreover, we are growing our continuing education program. This program is aimed at healthcare professionals like you and provide access to training in a self-study format. You can watch them whenever you want at a time that is convenient for your schedule. To learn more about these trainings, please visit the website on the screen. We will continue to add new material to the roster, so be sure to visit our website regularly or watch for our emails with updates and information. We know that the current situation presents many challenges for those affected by blood cancers and their families. The community services managers can help. They are compassionate connectors that can help those affected by blood cancers cope with the anxiety and isolation during these times. Please do not hesitate to refer your patients to the community services manager in your area. Before introducing our speaker, I want to inform you that the Canadian Council on Continuing Education in Pharmacy has accredited this program for 1.5 CEUs. Please fill out the survey that will be sent to you by email after the training in order to receive your statement of attendance. Also, this training has been approved for 1.5 ECUs from CEEP in an independent study program. Pharmacists have until April 15th, 2022 to attend the training and request their CEU. All right, so now it's time to introduce our speaker, Jennifer Voisey. Jennifer is a clinical pharmacist in the Adult Hematology Oncology Department of Eastern Health in St. John's, Newfoundland. Over to you, Jennifer.
Thanks, Charlotte, and thank you everyone for coming out here today. I know there's a lot of these educational and online events happening recently, so I appreciate you all taking some time to attend this one today. As Charlotte said, my name is Jennifer, and I'm a clinical pharmacist working in adult outpatient hematology oncology, and I'm based out of St. John's, Newfoundland. I graduated not too long ago from Memorial University's program, although sometimes it does feel like a lifetime ago. And I've been working here at the Health Sciences Center ever since I graduated. And I have cycled through a couple of different clinical roles. I started out in intensive care before moving to medical oncology, and then finally on to hematology, where I've been now for a couple of years. Throughout my career, I've stayed employed as a community pharmacist, so I do work regular shifts in community. So what I hope this has provided me with is a useful perspective from which to have put together this presentation tonight. I really tried to focus in on what I felt would be useful items that you could all hopefully take away and use in your practices. If nothing else, like Charlotte said, this program is accredited for 1.5 CEUs. So at the end of it, you'll at least get that out of it, but hopefully some useful information as well. In terms of conflicts of interest, I have received honorariums in the past from Janssen and AbbVie, but I have not received any funds from a commercial entity for today's presentation, although I am receiving an honorarium from the Leukemia and Lymphoma Society of Canada. So this is an outline of what we're going to talk about today. We are going to talk about chronic myelogenous leukemia as well as chronic lymphocytic leukemia. And for both of those, we're going to talk about etiology and symptoms, how we diagnose them, how we classify them or determine a patient's risk. Of course, we're going to talk about the agents that we use to treat them and the side effects that these agents can cause, and as well how we can manage them to help support patients so that they can get the best treatment outcomes possible. After that, we're going to talk a little bit about tumor lysis syndrome and prevention. We're going to have a little chat about common drug interactions and how you can manage them in your practice. And then towards the end, we're going to have a little chat about vaccines in this patient population and some references that you can use and have access to in your practice. So we have a lot to get through in the next little bit. So grab your cup of tea or your glass of wine or beverage of choice, and we'll get into it. Here's some learning objectives for today. I'm not going to take the time to go through them, but you can have a little read through. And we're going to jump right into what is leukemia. So leukemia is a cancer of the blood and bone marrow. And basically what it does is it affects white blood cells, and it causes an overproliferation of abnormal and unhealthy white blood cells. And these unhealthy white blood cells crowd out the healthy cells in the bone marrow and the body and prevent the body from making our healthy cells. So there's 4 types of leukemias, and they're broken into 2 categories. We have the acute leukemias and the chronic leukemias. The acute leukemias tend to be a little bit more aggressive in nature. They tend to grow fast and be a little bit more of an emergent situation, versus the chronic leukemias grow a little bit slower, and they're a less aggressive sort of leukemia. And as the title of today's presentation would suggest, we are going to talk about the chronic leukemias today. So we're going to start things off with chronic myelogenous leukemia, or CML. And this leukemia accounts for approximately 15% of all adult leukemias in Canada. It is a disease of slightly older age, no offense to anyone online of this age bracket, but it's generally diagnosed around 64 years old. That's the median age of diagnosis. We rarely see this one in children. It's slightly more common in males than it is in females, but it's no more common in any one ethnic or racial group over others. And as I sort of mentioned in the previous slide, chronic means indolent or slow growing here. So chronic myelogenous leukemia results from an acquired mutation that affects our hematopoietic stem cells. And we're not really sure what sets off this process, but what this mutation does is it results in a section of chromosome 9 switching with a section of chromosome 22, and they make a resultant chromosome called the Philadelphia chromosome. And this is present in about 95% of people with CML. So this is what is meant when you see sometimes patients denoted as pH positive or pH negative. It's referring to the presence or absence of this Philadelphia chromosome. And what the Philadelphia chromosome does is it creates a new gene called BCR-ABL. So a small number of patients will have the BCR-ABL gene, but an undetectable Philadelphia chromosome. And these patients have the same prognosis as Philadelphia chromosome positive people. And you'll have some patients who don't have the Philadelphia chromosome or the BCR-ABL gene, and these patients are labeled as having an atypical CML, and they generally have a poorer prognosis overall. So the BCR-ABL gene basically contains instructions that result in the overproduction of a protein called tyrosine kinase. And what this tyrosine kinase does is it allows too many white blood cells to proliferate. And these are unhealthy white blood cells. They're abnormal. They don't die and grow as normal cells will. And these diseased white blood cells build up in large numbers and they crowd out the healthy cells in the bone marrow. So you can see on the slide there to the right, I'm not sure if you can see my cursor, you can see this buildup of large unhealthy abnormal white blood cells versus this would be what a regular blood smear should look like. So the only risk factor that we know of for developing CML is exposure to ionizing radiation. Family history is not a risk factor. So if you have a family member that has CML, you are not more likely to get it. As I mentioned, it is an acquired mutation, which means it's one that happens after birth. And there's no universally accepted screening or prevention techniques for CML. The signs and symptoms are largely related to the crowding out of healthy cells by the white blood cells. So patients may have abdominal pain or early satiety or anorexia, and this could be due to the spleen being enlarged and sort of pushing on the stomach. They can also have bone pain from the crowding out of cells in their bone marrow, unexplained weight loss, fatigue, or night sweats. But I think it's important to note that up to 50% of patients will actually be asymptomatic upon their diagnosis. And most patients will be diagnosed during routine checkups or routine blood monitoring when abnormal white blood cells are found. So we can confirm the diagnosis of CML using a few different techniques. We can use some aspects of physical exam, so we can feel for the spleen, check blood pressure and pulse. We'll do blood tests. So a CBC, for example, will show an increased white blood cell count, especially in leukocytes. And we'll often see a decreased red blood cell count as well, and potentially a change in platelets. So patients' platelets can become too low or too high. Bone marrow biopsy is often done. We'll use this to look at the abnormalities in the bone marrow and to determine what phase a patient may be in. And we'll also use fluorescence in situ hybridization, or FISH, and polymerase chain reaction, or PCR tests. And we use these to look for the presence of the Philadelphia chromosome or the BCR-ABL gene. The PCR test is the most sensitive test to detect and measure the quantity of BCR-ABL in the bone marrow and our blood samples. So we tend to use that quite a bit. So there are 3 phases of CML, and the phase is determined by the proportion of diseased cells to healthy cells in the blood or the bone marrow. So chronic phase is the earliest phase. Patients are often asymptomatic here, and this phase is pretty responsive to drug therapy. Without treatment, this phase will typically last anywhere from 3 to 5 years. If left untreated, patients will then progress into accelerated phase, and this is sort of a transitional phase. Here, we'll start to see our drug options not working as well anymore. Patients will usually have some symptoms in this phase. Their spleen will be larger, their blood counts will be quite abnormal. And the duration of this phase is a few months without treatment before they progress onto blast crisis phase. Blast crisis is quite a severe aggressive phase. It's basically a transformation into a more acute leukemia. And patients will definitely be symptomatic here. Their blood counts will be completely wrong. They'll be all over the place. And it'll be days to weeks before death if a patient doesn't get treatment in this phase. But of note, most patients, about 90% of patients, will be in chronic phase upon diagnosis, so certainly very treatable. What are some of the prognostic factors that we have for CML? So the phase of CML, like we just talked about, those, as you can imagine, in accelerated or blast phase on diagnosis have a poorer overall prognosis. The older a patient is on diagnosis, the poorer their prognosis. If they have a quite enlarged spleen, they have linked that to a less favorable prognosis overall. And if their platelet count is quite abnormal, so really high or really low, that's been linked to poorer overall outcomes. And we'll use those prognostic factors along with scoring systems such as the Sokal score, the Hesford score, or the European Treatment and Outcome Study score to determine a patient's overall risk and guide our treatment decisions overall. So treatment of CML, what do we use? So until about the 1980s, CML was largely regarded as incurable and inevitably fatal for patients. We had approximately 2 treatment options. Patients could get a stem cell transplant or they could receive interferon therapy, but other than that, we didn't have a lot of good options. So the advent of tyrosine kinase inhibitors, or TKIs, really changed our management of CML overall. They improved the 10-year overall survival rate from about 20% to up to 90%, which is really quite remarkable. So today, most patients can achieve remission and live for many years after their diagnosis. And in fact, most have a life expectancy comparable to that of the general population. So it's certainly very manageable these days. I just wanted to put in a quick slide here on hydroxyurea. So sometimes when a patient has a suspected CML diagnosis, but we don't have that confirmation yet from FISH or PCR or bone marrow, we initiate them on hydroxyurea, particularly if their white blood cell count is severely elevated. And that's to rapidly reduce their white blood cell counts to a more normal range and avoid any complications from that. And we usually continue that until we have the confirmed diagnosis in the presence of the Philadelphia chromosome. And at that time, it can be discontinued. So I just wanted to put a slide in here on that because I have gotten questions sometimes from patients and from pharmacies about the hydroxyurea and why they're on it and when should it be discontinued and that sort of thing. So generally, patients will be on it till we bring their white blood cell count and have that diagnosis in place, and then we will start them on a tyrosine kinase inhibitor. So tyrosine kinase inhibitors, they are a type of targeted therapy. So what that means is they target and attack certain cells that are implicated in the proliferation of cancer cells. And we currently have 5 TKIs on the Canadian market right now. We have imatinib, and the brand of that is Gleevec. We have dasatinib, which is Sprycel, nilotinib, which is Tasigna, bosutinib, which is Basilif, and ponatinib, which is Iclusig. So those are our 5 options that we have right now. So these are all oral medications that would be prescribed to patients by their hematologist. And generally speaking, they would continue taking this treatment every day indefinitely. So basically, until they experience some sort of intolerance, that means we have to discontinue or change it, or until their disease progresses. I will say there is a growing body of evidence recently that suggests that patients can actually come off their TKIs if they reach their treatment targets. But I'm not going to get into that tonight. It's a lot to talk about. It's a subject on its own. So for purposes of this, patients would be on it indefinitely. They're all classified by NIOSH as hazardous medications, so they should be stored and handled appropriately that way. And their side effects are generally similar, but there are some differences that are used to help guide our treatment decisions for people. So how do these agents work? So TKIs basically block the ATP binding site on the inactive form of the BCR-ABL protein, and this prevents it from switching to the active form. And by doing that, we cut off that signaling pathway that leads to the proliferation of the CML cells. So by taking a tyrosine kinase inhibitors, we can reduce a patient's CML colony growth by up to 98% without having too much of an effect on healthy cells. They can sometimes have what we call off-target effects, so they can affect sometimes other signaling pathways, and that's where we see some of the difference in side effects come out from. So these are our first-line treatment options of chronic phase CML. We have imatinib, dasatinib, and nilotinib. So imatinib is a tablet that patients would take once a day. In terms of potential dose reductions, we may have to dose reduce it for hematologic reasons. So for example, if a patient's neutrophils go low, it should also be adjusted in renal impairment as well as hepatic impairment. It doesn't have to be taken with food, but it can cause quite a bit of GI upset sometimes, so there is improved tolerability with food. And it is metabolized by CYP3A4, and it's a substrate and an inhibitor, so it means it's rife for drug interactions. And one of them is warfarin. So warfarin is largely contraindicated with imatinib. If a patient needs an anticoagulant with this agent, a DOAC or low molecular weight heparin is preferred. Dasatinib is also dosed once daily, and it's also a tablet. It does not require dosage adjustment in renal or hepatic impairment. It can be with or without food. It is a CYP3A4 substrate as well, so unfortunately there can be some drug interactions here. This one we want to avoid PPIs with, so if a patient were to take a PPI with this, it could potentially decrease the concentration of dasatinib and lead to treatment failure. We can use antacids such as calcium carbonate or Zantac or ranitidine with proper spacing. So patients would want to space that out by at least 2 hours. And then we have nilotinib. Nilotinib is a capsule, and patients would take this twice a day. So this is a potential adherence issue for our patients, particularly when you couple it with the fact that it also has to be on an empty stomach. So patients need to take this 1 hour before or 2 hours after eating. So something to keep in mind for patients that could be a bit of an adherence issue. It doesn't require any dose adjustments in renal impairment, but it does in hepatic impairment. And lots of potential drug interactions here. We have CYP3A4, 2C8, 2C9, and 2D6 that this sort of works with. So we want to be careful there. Particularly, this one can also cause QT prolongation. So we want to be careful with other QT prolonging drugs or with patients who may be at high risk for QT prolongation. We need to avoid PPIs with this one. And we can use some antacids, but with caution and proper spacing. And honestly, the spacing here can be a bit difficult for patients to manage. So you would want to give the nilotinib 10 hours after or 2 hours before any kind of antacid. So important to know there. And these are our second line or treatment of accelerated or blast phase CML. So we have the same three agents. We have imatinib, dasatinib, and nilotinib. What I will point out here is that their doses are higher than what we use in first line treatment of chronic phase. So the doses are quite a bit higher. Everything else still applies for these medications though. And we also have the addition of bosutinib and ponatinib. So these are both medications that are tablets that patients would take once a day. Bosutinib does need some adjustment in renal and hepatic impairment, and ponatinib just in hepatic impairment. Both of them can be with or without food, and of course, both of them are CYP3A4 substrates, so we got to watch those other drugs with these. Bosutinib, PPIs and antacids aren't contraindicated as such, but there is some evidence to show that they may affect the concentration of it. So if a patient can avoid it, it would be good. So what should you do when you get a new prescription for a TKI? If you have access to clinic notes or blood work, for example, from a pharmacy network, it's a good idea to determine what phase the patient might be in so that you can validate the dose and ensure the patient's on appropriate dosing. You'd also want to examine the renal and hepatic function and make sure you don't need to make any dose adjustments there. Check for drug interactions will be a big one. And it's also a good idea to ensure your patient has coverage. So I know this varies from province to province, so I didn't get into it in this presentation. But here in Newfoundland, for example, these agents are not covered by hospital or by, free for patients. We have to get coverage of them through a private insurance or our government insurance program, and they usually require special authorization. And some patients may be left with a copay, and these aren't inexpensive agents by any means. So just to note that there are copay assistance programs available for every agent I'm talking about today. So if you notice that a patient seems to have a significant copay, there are programs to potentially help with that. And of course, you would want to provide appropriate patient education. So how do we know if a patient, how do we evaluate the efficacy of these agents for our patients? So once started on these agents, patients will typically get regular blood work to monitor their response to treatment. And it varies from center to center, but generally speaking, patients will get blood work every week to 2 weeks until their blood counts start to stabilize, and then they'll go down to monthly and every 3 months. And in general, the greater the response to drug therapy, the longer we can expect a patient's disease to be controlled. And optimally, we'll see patients respond to therapy within 3 months. So we have 3 types of responses that we look at. We have hematologic, we have cytogenetic, and we have molecular. So hematologic is measured with the CBC and differential. And we describe this as either partial or complete. And our goal is a complete hematologic response within 3 months. We can also look at a patient's cytogenetic response, and this measures the number of cells in the bone marrow that has that Philadelphia chromosome. So we define this as either a partial response, a complete response, or a major response. And then we can look at a patient's molecular response, which uses PCR to measure the number of cells with that BCR-ABL gene. And this is reported as a major molecular response, or 3-log reduction, or a complete molecular response, which would be a 4.5 or greater log reduction, or you'll also hear this called a deep molecular response. So what's our goal with these patients? At 3 months, we'd like to see a complete hematologic response. So basically, we would like their blood counts to be normalized. We would like to see a partial cytogenetic response, and we would like to see an overall decrease in their BCR-ABL transcripts. At 6 months, they should be maintaining that hematologic response. They should have a partial or better cytogenetic response, and a further decrease in their BCR-ABL transcripts. And at 18 months, they should be in major molecular response. So that's the goal. And what can you guys do to help achieve this goal for patients? So CML is, like I said, a chronic disease, and it requires patients to be on ongoing daily therapy. So anyone who's listening in here today who's had to take something daily, I can bet probably has missed a few doses at some points. And poor adherence to therapy has been identified in CML as one of the most important factors contributing to relapse for patients. There was one study I found where they where they found that patients with an adherence rate of less than 85% had a higher possibility of losing their response at 2 years versus those with an adherence rate greater than 85. So I think as frontline pharmacists dispensing these medications to patients, we're in an optimal position to help monitor adherence and help with side effects that may be affecting compliance to therapy. So I think it's a wonderful spot to step in and really practice some of your pharmaceutical care for patients. So let's talk about some of the side effects to expect. So hematologic side effects first. As wonderful as these agents are at attacking the disease cells, their effects can unfortunately sometimes spill over into our healthy cells. So patients can sometimes experience neutropenia, anemia, or thrombocytopenia with these therapies. It is most common at the start of treatment. So something to watch out for, I would say, in the first 3 months or so that a patient starts treatment. Let's start with neutropenia. So neutropenia refers to a decrease in neutrophils. Normal range for patients is somewhere between 2 and 7.5. So when a patient drops below that, basically what it means for them is that they may be at an increased risk of infection. So one thing I always tell my patients is I chat about temperature monitoring with them. So patients should be recommended to pick up a thermometer. It can be any cheap thermometer, just something that will check their temperature, and monitor for fevers, particularly if they're feeling unwell. And if a patient has a sustained fever, so if they develop a temperature reading 38 degrees or higher, and that's sustained for 4 hours or greater, they really should present to the emergency room for evaluation, get some blood work done, and see if they're potentially at risk for febrile neutropenia. They should be counseled to practice proper hand hygiene and infection techniques. That's really easy to do these days with COVID. Most people are aware of that. And if they feel that they have an infection, so mucus production, sore throat, cough, they should really see a physician to get that looked at in case they need treatment with an antibiotic or similar. Thrombocytopenia refers to platelet count. So if a patient's platelet count drops too low, what they'll be at is an increased risk of bleeding or bruising. So I usually counsel them on that. If they fall down or hit themselves and they notice large areas of bruising that seem a bit abnormally large, they might want to present for evaluation. If they cut themselves or develop a nosebleed and it doesn't stop in a reasonable amount of time, so for example, 15 to 20 minutes, again, they should present to the emergency room for blood work to see if their platelets have gone too low. And anemia refers to our hemoglobin. So if a patient becomes anemic, they may notice that they feel weak or fatigued or a bit short of breath. So to counsel them on the signs of that is important. Generally speaking, we're not usually super concerned about these effects until they reach what we call grade 3 or grade 4. So those grades refer to the CTCAC grading system. So that's sort of an adverse effects grading system that we use in oncology to determine how severe a side effect is. So if a patient becomes grade 3 or grade 4 neutropenic or thrombocytopenic, sometimes their treatment may have to be held for a period of time and then restarted potentially at a lower dose. So just something to note there. With regards to thrombocytopenia, I will always check a patient's home medications for anything else that might have anticoagulant or antiplatelet properties. And if there's something they're taking that maybe they don't need to be taking, I will usually suggest discontinuing it. So a big culprit here is baby aspirin. A lot of patients will take baby aspirin because they've heard it's healthy, but they weren't necessarily told they had to take it. So I'll often tell them to discontinue that so we're not adding to that bleeding risk with these agents. Firstly, I apologize for the creepy picture. So many people have told me this is creepy, and I'm sorry. So anyone who has dozed off is probably awake now. But these agents can cause edema or fluid retention. Imatinib is the worst offender for this. So we can have peripheral edema and fluid retention, and this often presents as swelling in the hands or feet. For this, I'll usually tell people to elevate their hands and feet, limit sodium intake if possible. Sleep sitting up is also helpful. Imatinib specifically can also cause periorbital edema. So that's what you're seeing in the picture there. Is sort of bags of fluid under the eyes. Again, limiting sodium intake here is helpful, as well as hydrocortisone 1% cream or phenylephrine cream. And if you're not recognizing that phenylephrine cream, that's preparation H. So it's a vasoconstrictor, so it can help to bring down that swelling under the eyes. Some patients may need a low dose of furosemide if they have a bit of edema. So 10 or 20 milligrams once a day for a period of time to get off that extra fluid. For patients, I just tell them to monitor it. They can also monitor their weight for rapid weight gain, which would be a sign of edema. And I suggest the management strategies that we just discussed as needed. Cardiovascular effects. So the big offender here is nilotinib, which can cause QT prolongation. So with nilotinib and dasatinib, I like to ensure that an ECG has been done at baseline or that one is scheduled within a week of starting the medication. I also like to calculate a person's overall QT risk, and I like to use the Tisdale score for this. So as part of the Tisdale score, I would look at electrolyte abnormalities such as potassium, age, sex of the patient, and number of other medications that they're on that may cause QT prolongation to come up with an overall risk. I'll also counsel patients on the signs and symptoms of QT prolongation. So I'll usually tell them if they get chest pain or heart fluttering or sudden lightheadedness, they should definitely present to emergency to be evaluated for potentially QT prolongation. Hypertension is possible with ponatinib more so than the others. So patients, I will just usually tell them to monitor their blood pressure. If they have a blood pressure monitor at home, that's great. They can check it, a couple of times a week, or even they can check it when they come into the pharmacy. If they start to notice their blood pressure creeping up, I'll then refer them to their physician for management. So they may need to be started on an antihypertensive, or if they're already on one, they might need to have a dose increase. In terms of general side effects, diarrhea, bosutinib is particularly bad for this, followed by imatinib. Loperamide is totally fine to use here, and I just counsel patient on sort of the standard dosing of that. I do go up occasionally above the recommended dose that's on the box if patient's diarrhea is just not clearing up for them. I think it's also important to talk to them about maintaining hydration if they're having diarrhea. So we want to make sure they don't become dehydrated. And I also counsel them on some warning signs to look out for. So if they develop abdominal pain or fever or blood in the stool, anything like that, they should, of course, present for evaluation at the emergency room. Nausea and vomiting can occur with all of these agents, but is more common with imatinib and bosutinib. The first thing I usually do is I suggest they take it with food if they're not already doing so. And then the second thing I'll do is I'll use my minor ailment prescribing skills and prescribe them an antiemetic if needed. There's a number of agents we can use here, so I encourage you to just look at your patient, their comorbidities, other agents that they're on, and select something that'd be most appropriate. Gravol is fine to use. I also use a lot of metoclopramide and a lot of prochlorperazine, but there are a number of agents here. Rash occurs in quite a lot of patients, so in up to 50% of patients, they'll get a rash, and this is due to, again, off-target effects of these drugs, so they do affect EGFR at times. I find the rash is very easily cleared up with just a mild steroid cream, so a 0.5 or a 1% of hydrocortisone, and I'll sometimes add on an antihistamine with that as well, so something like a cetirizine or a loratadine, and it generally clears the rash up for people. If not, I step them up to a stronger steroid cream, and that generally does the trick. It's very uncommon that we would need to discontinue the agent entirely due to rash. And then general aches and pains can happen with all of these agents. And in terms of our over-the-counter options, we are a little bit limited. So Nsaids are basically not recommended in this patient population. So Advil, Aleve, all the Nsaids can sort of potentiate that antiplatelet effect. So it could increase a patient's risk of bleeding. So we don't want that. And actually, ibuprofen and NSAIDs in general interact with imatinib and decrease its efficacy, so we don't want to use those. I'll usually go to Tylenol if the patient doesn't have any other contraindications. And what's important here is that Tylenol can, of course, mask a fever, and we don't want to do that. So I'll usually tell patients not to take it regularly and to have breaks between their doses and to check their temperature between those doses so we can make sure we're not masking a fever here. If you have access to a patient's blood work, you can check their ANC and make sure that they're not neutropenic and at risk for fevers or infection. And in terms of other side effects, we can get elevation of liver enzymes with all the agents. So I'll counsel patients on signs of that. So if their urine becomes darker or their eyes become a bit yellowed or they have abdominal pain or nausea, they should present to get evaluated for that. If a patient has a history of hepatitis B, they're also at risk of reactivation of that. So they should be on prophylaxis for the duration of their treatment with an agent such as lamivudine. And nilotinib specifically can cause hyperglycemia. So if you have a diabetic or pre-diabetic patient, it's important to counsel them to monitor their sugars more frequently, especially in the first few weeks that they're on nilotinib, and their diabetic medications may need to be adjusted accordingly. So I wanted to make this a bit interactive and wake up anyone who might be sleeping and suss out who might have started the presentation and walked away. So we do have a bit of a case study here in which we have a polling option set up. So we're going to do a little quiz, but I do believe the responses are anonymous, so don't worry, it's just meant to be good fun. So this first one here is really going to test how well some people paid attention. So you're working in a pharmacy and LM, a 67-year-old male, approaches you with a prescription for the following: nilotinib, 300 milligrams PO twice a day. What indication do you think LM is using this for? Is it A, first-line treatment of chronic phase CML, B, second-line treatment of accelerated phase CML, C, second-line treatment of chronic phase CML, or D, first-line treatment of accelerated phase CML? And I believe Sonia is going to pop up a quiz option soon. So we'll give you a bit of time to answer, and in the meantime, I'm going to take a sip of water. All right, so if you say, oh, lots of people paying attention. So yeah, that is the dosing for first-line treatment of chronic phase CML. And here you go. So LM's other medications include ramipril 10 PO daily, atorvastatin 40 PO daily, rabeprazole 20 PO daily, metformin 500 PO BID, and lorazepam 0.5 sublingual PRN. You go to fill his nilotinib and you get an interaction pop-up window with a serious interaction. Oh no! Which one of his home medications do you think it's about? A, ramipril, B, atorvastatin, C, rabeprazole, or D, metformin? This is slightly a trick question, but we'll have a chat about it. And the answer is indeed rabeprazole, although the people who answered atorvastatin and metformin, we'll chat about that in a little bit. So yeah, as I mentioned, rabeprazole or a PPI is generally contraindicated with nilotinib. And that sort of leads us into our next question. So you've identified that rabeprazole interacts with LM's nilotinib. What is your management strategy? A, advise monitoring for increased effects of nilotinib. B, create a plan and follow up for discontinuing rabeprazole. C, fax the physician and suggest an alternate TKI. Or D, nothing, this interaction requires no management. Awesome. I love seeing. I'm glad no one answered nothing. So yeah, I personally think the best option here would be to create a plan and follow up for discontinuing rabeprazole. Perfect chance to deprescribe something. That's a big initiative here in Newfoundland. A would be incorrect because actually we would expect decreased side effects of nilotinib. C, I guess is not wrong. It's maybe not the most efficient answer. It's probably a bit easier to see if we can get rid of that rabeprazole first. And D, I would say is incorrect. I would think that this interaction needs some sort of management. And last question, was there any other potential interactions you identified? A, nope, all good. B, LM may experience increased effects from atorvastatin. C, LM may experience an increase in his blood glucose levels. Or D, both B and C. Awesome. Yeah. If it's one thing I learned in school is that if there's an option for like all of the above or multiple answers, that's always the right answer. So yeah, because nilotinib is a CYP3A4 substrate and inhibitor, we would expect maybe an increase in effects of atorvastatin. And as we talked about, it can increase blood glucose levels. So he can expect maybe both of those. I'm glad everyone's paying attention. So on that note, we are putting CML to rest and we are going to move on to chronic lymphocytic leukemia or CLL. So this is the most common adult leukemia in North America and Europe, and it accounts for roughly 44% of leukemias diagnosed in Canada. The median age at diagnosis is about 71 years old, and again, it's slightly more predominant in males than it is in females. And like CML, it's considered quite an indolent disease, and survival following diagnosis without any treatment is anywhere between 1 and 20 years. Similar to CML, it's traditionally been considered incurable, but we do have a lot of new agents we can use, and these have led to some long and durable remissions for our patients. So I'm just going to direct you to this picture on the right here. So CML affects the myeloid stem cell line, which would be this stem cell line here. And CLL, which we're about to talk about, affects this lymphoid stem cell line. So this stem cell line on the right. And the majority of those changes occur in these B lymphocytes, with a small percentage occurring in these T lymphocytes here. So basically these lymphocytes, they don't function normally, and like in CML, they accumulate in the marrow, the blood, the spleen, and the lymph nodes, and they crowd out our healthy cells. So they survive a lot better than our healthy white blood cells, and over time crowd them out. So risk factors, there are no known risk factors to developing CLL. Environmental factors such as radiation or chemical exposure have not been linked to the development. But unlike CML, there is a genetic component here. So if you have a first-degree relative that has CLL, for example, a parent, you are 2 to 4 times more likely to develop the disease. And there's no universally accepted screening or prevention techniques for CLL. Signs and symptoms, again, are largely related to the crowding out of our healthy cells by the disease cells. So we'll get accumulation of the disease cells in lymph nodes, in the neck, the underarm, or the groin. Patients might have a feeling of bloating or a feeling of fullness or abdominal pain. They might have unexplained weight loss, fatigue, night sweats, and increased risk of infections and low-grade fevers because they don't have a properly functioning immune system with white cells that function like they should. Similar to CML, a lot of patients will be asymptomatic, so about 25% of patients won't have any symptoms at all upon their diagnosis. And similar to CML, a lot of patients get diagnosed when they have a routine checkup that shows something abnormal in their blood work. So diagnosis, again, we can do a physical exam. We can feel for those enlarged lymph nodes. We can do blood tests and look at their CBC. We can do immunophenotyping, and immunophenotyping is done with an instrument called a flow cytometer. And basically what this does is this measures the number and the characteristics of specific cells in a sample. So we can use this to see how many abnormal B lymphocytes are in a sample. We can do a bone marrow, although it's not as necessary in CLL as it may be in CML. And we can look at immunoglobulins. So immunoglobulins are proteins called antibodies, which are made by B cells in healthy individuals to protect the body from infection. So CLL cells do not make effective immunoglobulins, and they also interfere with the ability of our healthy cells to make the immunoglobulins. So as a result, people with CLL will have low amounts or abnormal immunoglobulins, and this is also why they're at an increased risk for infection because they have an immune deficiency because of this. So prognosis, like I said, CLL is an indolent disease, and some patients can live quite a long time without any treatment at all. However, some patients may have higher risk features, which do lead to a poorer prognosis. So there are a few cytogenetic abnormalities which have been correlated to a patient's risk. So if you look sort of to the right of the slide here, this is some of the abnormalities a patient can have. So for example, if a patient has a 13q deletion, this is actually associated with a favorable outcome. But if a patient has a 17p deletion, that is associated with a higher risk or poorer prognosis. Recently, we've also been starting to look at IGHV mutational status, so immunoglobulin heavy chain variable region mutational status as a predictor of prognosis as well. So if patients are found to be unmutated IGHV, this has been associated with a poorer prognosis. So the decision whether or not to start treatment is generally based on these patients' risk factors and the stage of their disease. Patients with early stage and asymptomatic disease may actually benefit from just a watch and wait approach. They may not necessarily need treatment right away. When we do decide to start treatment, we do have a variety of options available. So we can use single or combination chemotherapy using IV or oral drugs. We can use targeted therapies, and we can use monoclonal antibodies. So today we're going to be talking about our oral targeted therapies that we can use. And when we select these agents, it's important to remember that this is a disease primarily of elderly patients. So we need to really keep in mind their comorbidities and their performance status before we start these treatments. So these are our targeted therapy options for CLL available in Canada today. So we have kinase inhibitors, and under those we have Ibrutinib and Cll. And then we have our BCL2 inhibitors, which right now is just venetoclax. So we're going to start with the Bruton's tyrosine kinase inhibitors. So let's see if I can get this right for you guys. So Bruton's tyrosine kinase it's right here. It's a kinase that's located in CLL cells, and it's essential for transmitting signals from the surface of the cell into the CLL cell. And its main role is related to the B cell receptor located here, which is a key molecule on B cell lymphocytes and also on CLL cells. So when this gets activated, it transmits a signal into the CLL cells that's needed for their growth and survival. So basically, the Bruton's tyrosine kinase inhibitors come in and block this pathway, which leads to cell death. So like I said, we have two available. We have Ibrutinib. It's an oral capsule. Patients need to take it once a day. It doesn't need any dose adjustments for renal impairment, but it does for hepatic impairment. It can be taken with or without food, but we need to avoid grapefruit. It is a CYP3A4 substrate, and it's a major one. So there we go. There's another potential for some drug interactions. And of note of drug interactions, warfarin is pretty much contraindicated with Ibrutinib due to bleeding risk. So if a patient needs to be on anticoagulation, a DOAC or low molecular weight heparin is preferred. And of course, it can interact with CYP3A4 inhibitors. Acalabrutinib is twice daily dosing. So again, something to keep in mind for patients in terms of adherence. It can be used in renal and hepatic impairment, but if a patient is severely hepatically impaired, so Child-Pugh class C, it's suggested to avoid its use. Taken with or without food, it is also a CYP3A4 substrate. Warfarin is also contraindicated with this agent, as well as PPIs. So again, patients can't take PPIs with this one. It will decrease the concentration and potentially lead to treatment failure. If they need to take something, so for example, a Tums or a ranitidine, we need to do proper separation, so separate by at least 2 hours.